My name is Eelco Brand. I'm a PhD candidate from the University Medical Center in Utrecht. On behalf of my co-authors, I would like to thank Gastrointestinal Endoscopy for the opportunity to discuss our article entitled Missed Adenomas with Behind-Folds Visualizing Colonoscopy Technologies compared to Standard Colonoscopy. A pooled analysis of 3 randomized back-to-back tandem colonoscopy studies. My co-authors are Vincent Dick, shared first author, who is a gastroenterologist in training at the Antonius Hospital in Nieuwegein. Martijn van Ooyen, clinical epidemiologist and associate professor at the Department of Medical Oncology in the Academic Medical Center in Amsterdam, and Professor Siersema, Professor of Endoscopic Gastrointestinal Oncology at the Radboud University Medical Center in Nijmegen, all from the Netherlands. It is well known that a substantial proportion of polyps and adenomas are missed during colonoscopy. Missing these lesions might ultimately lead to the occurrence of interval colorectal carcinomas. Multiple factors have been found to be associated with missing colorectal adenomas, such as poor bowel preparation, shorter withdrawal time, flat morphology of the lesions, and localization behind colonic folds and inner curves, amongst other factors. Several new colonoscopy technologies have been developed to improve the detection of colorectal adenomas and serrated lesions. For example, chromoendoscopy and virtual chromoendoscopy, high-definition colonoscopy, wide-angle colonoscopy, and technologies to improve the visualization behind colonic folds. 3 of these behind-folds visualizing technologies, namely the third eye retroscope, the full spectrum endoscope, also known as FUSE, and the Enderings device, have recently been shown in randomized back-to-back tandem colonoscopy studies to decrease the proportion of missed adenomas, in other words, to decrease overall adenoma miss rates. However, the question remains for what types of adenomas and in which subgroups of patients these behind-folds visualizing technologies mostly reduce adenoma miss rates. In our pooled analysis of 3 randomized back-to-back tandem trials, including 650 patients, we found an overall adenoma miss rate of 36% with standard colonoscopy compared to 14% with behind-folds visualizing colonoscopy. The adenoma miss rates were statistically significantly decreased with behind-folds visualizing colonoscopy compared to standard colonoscopy for adenomas smaller than 10 mm, adenomas located both in the proximal and distal colon, and adenomas with C-cell and flat morphology, as was the case for C-cell serrated polyps. However, for adenomas larger than or equal to 10 mm, advanced adenomas, and tubulovillous adenomas, there was no statistically significant difference in adenoma miss rate. If we look at patient subgroups, adenomas were less frequently missed with behind-folds visualizing colonoscopy regardless of sex of the patient, indication of colonoscopy, and the age of the patient, except for patients younger than 50 years. Within the group of patients undergoing behind-folds visualizing colonoscopy first, a significantly smaller proportion of patients had changes in their surveillance intervals due to findings during the second colonoscopy, compared to patients who underwent standard colonoscopy first. Standard colonoscopy is known to be less protective against proximal colorectal cancer. This might be caused because more difficult to detect lesions, such as flat lesions and serrated lesions, are more often proximally located. It is therefore tempting to speculate that our findings that these lesions are less frequently missed with behind-folds visualizing colonoscopy could decrease the risk of interval colorectal cancer. However, larger prospective studies with longer follow-up are needed to confirm this. The long-term effects of lowering adenoma miss rates with behind-folds visualizing colonoscopy technologies therefore remain to be elucidated. In conclusion, the use of behind-folds visualizing colonoscopy technologies reduce miss rates for adenomas 1 to 9 mm in size, located in all segments of the colon, as for flat adenomas and C-cell-serrated polyps, whereas no advantage was found for adenomas larger than or equal to 10 mm and advanced adenomas. Further studies are needed to confirm these results in larger populations and to investigate which technology is preferable in what type of patient. Finally, an important question is of course whether the detection and removal of more small-sized adenomas with a behind-folds visualizing technology will indeed reduce colorectal cancer incidence and mortality. I would like to thank you all for your attention.